Hey, welcome to the Healthful Woman podcast, the fastest growing podcast in women's health. Today's Monday, August 4th, 2025. August. Today I'm joined by Dr. Celia Muoser, who is an MFM in my practice at MFM Associates in New York City. We are delighted that Celia joined our team about a year ago, and this is her first voyage on the podcast. Celia and I are going to talk about antenatal corticosteroids, which are given to women at risk for preterm birth. Great OB topic. Next week, we're going to have a mailbag podcast, so keep sending in those questions. All right, thanks for listening. We'll see y'all next week. Welcome to today's episode of Healthful Woman, a podcast designed to explore topics in women's health at all stages of life. I'm your host, Dr. Nathan Fox, an OBGYN and maternal fetal medicine specialist practicing in New York City. At Healthful Woman, I speak with leaders in the field to help you learn more about women's health, pregnancy, and wellness. All right, Dr. Celia Muoser, welcome to the podcast, your maiden voyage into the podcast here. This is great.
Thank you. Excited.
Yeah. Have you podcasted elsewhere and just not here, or you've never done it before?
Definitely not. First ever podcast.
How's it going so far?
So far, so good.
All right. Well, you sound good. The headphones are on right. The microphone's set up. You're doing a good job.
Yes, professional.
Just as a little background, so you joined our practice a little less than a year ago. How's that been?
Oh, that's been great. I think about 6 months now. So definitely settling in. Everyone's great. A good experience and great patients too.
Yeah. All right. So tell our listeners, what do they need to know about you? You know, where you're from, where you train. Give us the story.
I'm from here. I feel like that's what I always start with. Born in the city and grew up outside the city in Westchester, Dobbs Ferry,
Right.
and then was in upstate New York for school, for college, short time in Boston for medical school at Tufts. And then I've been back in the city the last few years. So sort of went straight through in school. So I'm not young, but in theory, I'm the youngest you can be, though it's not young.
Yeah. I remember when I finished my training, it was something like 20 plus years of schooling, like whatever it is.
Yeah.
It's crazy. I mean, you're well trained. And so you're an OBGYN and you're a maternal fetal medicine specialist,
Yes,
right? So here
correct.
we are. You're an MFM and doing your thing. It's great.
Yeah. And so then I did residency and fellowship at Montefiore in the Bronx. So I've been in the city, but now back in Manhattan.
Terrific. Well, we're happy to have you. Our patients are happy that you're here. Most importantly, I'm glad you're podcasting.
Most importantly.
You know, we all have our needs. So we were trying to come up with something to talk about that was a little bit on the MFM side and something that's important, but something maybe we didn't cover before in the podcast. And you had a really good idea to talk about antenatal corticosteroids, or what we sort of refer to as steroids, basically. And so just for like a general overview, very high level for our listeners, like what are we talking about here? Like why steroids? Like we're not weightlifters, we're not baseball players. Like what are we talking about?
Great question. So this is something that comes up pretty often for us, especially as MFMs. And the whole idea is a very short course of steroids that we give to patients, mostly not for you, actually for your baby. It's something that can help your baby's lungs to develop in the case that we're thinking about an early delivery.
Yeah. So in terms of the high level, it's something that it's a really interesting phenomenon that there are things that we give to the mother while she's pregnant
that are not for her.
Right. That not going to help her, right? I always say it's not going to make you a better baseball player, not going to do anything to you. And we'll talk about it, like, doesn't really even have a lot of side effects even because it's a very short course. But we're giving it to her if/when, right? We don't always know, but if or when she's about to have a preterm delivery, that premature baby does better if the mom got the steroids.
Exactly.
Right. Which is it's not like a crazy concept, right? It makes some sense, but it's just a very interesting phenomenon that a lot of what we do, it's like we're giving the mother medication because when the baby, let's say a week from now, is in the NICU, he or she's going to do better because of that. And it's just really neat, actually.
It is. It's like the second patient. We always have two patients and we're thinking about both of them. Yeah. And so I think it's kind of like the epitome of what we do in OBGYN and MFM.
And it's in this, I have this conversation a lot with people in terms of other things, not related to steroids specifically, but some of the screening tests we do in pregnancy, like for example, like cervical lengths, right? So
Yeah.
there's this whole debate about like, should you do them? Should you not do them? And one of the main arguments against checking someone's cervix in pregnancy is that, well, okay, you're going to learn if someone is or is not at high risk for preterm birth, but what are you going to do to prevent the preterm birth? And what I say is, I agree. Our ability to prevent preterm birth is very, very limited.
Yeah.
But if I know someone's going to deliver preterm or higher risk to deliver preterm compared to somebody else, I can sometimes give her those treatments.
We can prepare for
Yeah,
it.
we can prepare. And so I say, like, the analogy I usually give is like, if I check my weather app in the morning, it's not because I can prevent it from raining.
That's a great
But
analogy.
if I know it's gonna rain, I'll bring an umbrella, right? And so like if I know someone's gonna deliver preterm, or I think someone's gonna deliver preterm, I'm not gonna prevent that. But the umbrella here is the steroids. Like, okay, this is the person as opposed to the other 99 people. This is the one who needs the steroids and other things. But we're gonna focus on steroids today. Yeah, that's the analogy I use. You can use that.
That's perfect.
Yeah, weather. It's always good. Checking the weather. So, all right. So let's get. So that's a great introduction to what we're talking about. And sometimes you'll hear them referred to as steroids, just like that. Sometimes corticosteroids.
Mhm.
Sometimes antenatal corticosteroids. Antenatal just means giving them during pregnancy.
Yep.
Sometimes you'll hear us say referring to beta, right? Which is
Beta, not the zone.
yeah,
Our
or
favorite.
BMZ, like Bob, Mary, Zebra, right? Which is short for beta methazone. These all mean the same thing.
Yes. Yes.
Okay, so question. How does giving steroids improve the outcomes for the
Great
baby?
question.
Like what's going on here?
Great question. So the answer to that is really that we think that the steroids are acting on some of the cells and the linings of the lungs, the pneumocytes specifically.
Yeah.
And it helps to improve
This is the baby's lungs.
the baby's lungs,
Yeah.
not mom's lungs,
Yeah.
baby's lungs. And it helps to improve their maturity and helps them to have a better effect on gas exchange when the baby is born. So reducing things like respiratory distress syndrome, reducing the amount of respiratory or ventilatory support the baby needs after delivery. So that's sort of the biggest category that we're thinking about with steroids. So there are other.
Right. I mean, and respiratory, like breathing issues, tends to be, for most premature babies, the biggest issue.
Yes.
Right. Is
one
the
of
baby on a ventilator? Is the baby not on a ventilator? Does the baby need oxygen? How much oxygen? Because the lungs are one of the last organs to sort of catch up.
Yep.
And so that's the main mechanism. So let me ask you this question. If they improve the lung function for babies, why don't we just give them to everybody when they're pregnant? Why wouldn't you just say, okay, just like we take a prenatal vitamin or whatever it is, why don't you just give steroids to every pregnant mom at a certain point in pregnancy, 24 weeks, 26 weeks, 28 weeks, whatever it is?
That's a good question.
Thank you.
And the answer is that, well, we think a short course is safe. There are sort of some effects to being on steroids long-term, to getting multiple courses. And probably the majority of people don't need them. That's why we don't need to give them to everyone. So we really sort of want to risk stratify, who will benefit from them.
Right. I think also one of the really, you may be too young for this, but are you aware of the Price is Right game show?
Yes.
Yeah. So maybe our listeners are, maybe they aren't. So some of it is like the thing when you're guessing the price, but you can't go over, right? So with steroids, they do improve lung function for the premature newborn, but the benefit is highest if you give it within a week of delivery, maybe within 2 weeks.
Yes.
So like shorter. So if I gave it to everybody at 24 weeks, it would really only help the ones who happen to coincidentally deliver in the next week or two, which is going to be the minuscule number of patients. But if someone's delivered at 31 weeks, it may not be as beneficial, and you wish you could go back and give them at 30. So we're sort of like playing this high stakes game, so to speak.
And we can't keep giving them.
Right. So you get one, and we'll talk maybe two chances at this. And so you definitely want to give it to everyone who's going to deliver preterm
As best as you can predict
but you
that.
don't, but you want to get it as close to delivery as possible without going over, without missing it. And so the strategy of giving it to everyone really is, no one does that because it's really not going to work. And so we do all these things to try to figure out, does someone need it or does someone not need it? And sort of that's why we have a job, to sort of like to help work all this out, to see who gets it, when should they get it, and all of that. But that's the reason we don't just give it to, to everybody, because that's usually the first question people ask. Well, if it helps the baby, why don't you just give it to everybody?
Yeah.
So it won't help the baby unless we time it right and give it to the right person. Like you said, maybe there's side effects of you gave it to the whole population, but it's more so, I think, timing that is safety. Okay, so when is the timing that we typically would give steroids? Like, not, I don't mean in terms of prior to delivery, but like at what gestational age would we typically give them?
So that's a really good question. And we can start to give them as early as we think a baby might have a chance to survive if they were born. So it can be as early now, even as 22, 23, 24 weeks.
Mm-hmm.
We do know that probably the benefits are bigger and more significant for those babies that are born really, really early. So we can give them from that point on, in theory, up now, basically until term.
Yeah.
Definitely before 34 weeks. And there's some new data for that last late preterm period.
Yeah, it's such an interesting story because, when I was training 150 years ago, the rule, the tenet was you give steroids between 24 weeks and 0 days and 33 weeks and 6 days, right?
Yep.
So 24 to 34 weeks. And then the only stretching you would do on that is if someone came in, let's say at 23 weeks and 6 days, and you thought they were going to deliver the next day at 24 weeks, you would give them, fine. And so that's when like the majority of studies were done. That's sort of the data that we have. All the stuff about improving outcomes and lowering the chance of respiratory and, the neonatal death, like all these things is for 24 to 34 weeks. So that was sort of like the rule, and you did not give them earlier. But the reason we didn't give them earlier was, number one, we weren't sure if it would work because it's just a fascinating thing. In order for the steroids to affect the lungs and the pneumocytes, there have to be lungs.
Yes.
And pneumocytes. And earlier, the lungs aren't developed enough maybe to even respond to
have
it.
any effect at all.
Yeah, so we weren't sure if it was going to work. And number two, the chance of the baby surviving under 24 weeks was so low, if not zero, that it was like, well, what's the point? Like, what are we improving? And so that was the rule. But over the course of, starting around the time I was training until now, number one, some babies under 24 weeks are going to survive, obviously more so at 23 weeks than 22 weeks and less so at 23 weeks and 24 weeks. But okay, some do survive. And we have started to accumulate more data on those babies showing that if they survive, they're better off having been exposed to steroids.
Yeah.
So we stretch it as early as if we think the baby might survive and they're going to try to save the baby, so to speak. Usually everyone says, well, may as well give steroids because it'll probably work.
Yeah.
But that's, a relatively new phenomenon, new meaning past, 10, 15 years as opposed to, 50 years or whatever it is.
You're not that old.
Correct. Thank you. But I assume when you were training, it was pretty routine to give them at 23 weeks. Yeah, and maybe 22 would have been the stretch probably when you were training, is my guess.
Yes, that's correct. Also, when I was training, that's when we started the late preterm steroids. That was in my residency.
The other end. So that's like 30, right? Because for our listeners who know and are very educated on this, they're like, wait a second, you only give them to 34 weeks, but premature is under 37 weeks. What about those 34, 35, 36 week babies? And so tell us about that. What happened with that end of the gestational age window that we started to stretch it a little bit?
So, essentially, we do think that the benefit probably becomes sort of less in magnitude the closer we get to term, because we do think the lungs are more developed and most babies probably won't need it. But there was a sort of landmark study or trial that came out when I was in my residency looking at sort of a late preterm steroids.
Right.
And they did find there probably was some benefit in the late preterm period. So that's in, the 34th, 35th, 36 weeks. And they found that there was probably some decrease in need for respiratory support for babies who got it within that time period. And there wasn't sort of an increased risk of things like infections for the baby, sepsis. So offering that to patients and discussing that option with them became more a part of practice.
Yeah, definitely. I would say, again, when I was training, it was like sacrilege to give them after 34. You were like beaten over the head if you gave them after 34 weeks. It doesn't work, this, that. And someone said, well, why would it work at 33 weeks, 33 and a half weeks, and then not work at all at 34 weeks? Like it would make sense, and maybe it works a little bit less, right? It doesn't work as well, but whenever there's like a very hard line cutoff in medicine, it's often
it's arbitrary.
Yeah, it's like, why then?
Or it's how we've studied it in the past.
Yeah, and the way the data shook out in that study is, as you would expect, the greatest effect was for babies at 34 weeks, followed by 35 weeks. And then 36 weeks, there was much less effect, which makes complete sense to anybody who just thinks about it. Like, of course. And it's hard to prove anything because almost all babies born at 34 and 35 weeks are going to be fine.
Yes.
And so how much more fine can you make them, right? If a baby's going to be perfectly healthy, how much better can you do it? So I'd say look at things like going to the NICU, time in the NICU, which is important, but it's not long-term, like serious issues. It's like, if I could shorten a NICU stay from 4 days to 2 days, like that's valuable, obviously, but it's not quite the same outcome as, your child will or won't have long-term lung issues,
Yes.
right? Those are very different, conversations. And so at the 34, 35, 36, it's more of these sort of like smaller type of outcomes that we're talking about, which is why there is more discussion. It's not as black and white that someone must have them or must not have them. There's some discussion and there's definitely much more variation and practice out there around the world, around the country and between doctors of what to do during that gestational age. There's, I don't know if you ever had this, but like, when you were training, but there's also a question about maybe people who have C-sections who are like 37 weeks even, maybe they'll benefit from steroids, and some studies show yes, no. And why would how the baby's being delivered, C-section versus vaginal, affect how steroids would impact them?
And so the babies actually get some benefit from that transition period when they're having a vaginal delivery. And having a vaginal delivery actually decreases your risk of having, sort of difficulties of breathing right at delivery, even for term babies.
Right. Just because they're getting squeezed.
Yep.
It's good to get squeezed. So like C-section, we sort of like pull them out of a pool of water.
Just shocking. You're here.
They don't have as much time to like, get the water out of their lungs and this. So there's, and that's not, I would say most
do
places,
well that are born.
All those babies generally do fine. And I would say that most places around the country and around the world would not be giving steroids after 37 weeks. But some places, and we've done this also time to time, will give them at just like a 37 weeks if it's a C-section plan, things like that. But it's the data on that's much more mixed, whether it is or isn't helpful. But that is, some people might hear about that in a certain sense. Now, if the mom, let's say decision's made to give her steroids, like, all right, we think you're at high risk for delivering either because you're in preterm labor, your water's broken, or we think you need to deliver because your blood pressure's high or whatever it is, what happens logistically? What are we talking about? How does the steroids get given to the mother?
Good question. So it's an intramuscular injection.
Mm-hmm.
The most commonly used injection is the betamethasone. That's the most common formulation of steroids that we use. And it's 2 doses that are given 24 hours apart. So we say 48 hours after the first dose, 24 hours after the second dose, you're what we call steroid complete. You've completed the whole course. It's only those 2 doses.
Right. So 2 injections.
2 injections. There's another form, dexamethasone, that is also sometimes used. That's actually 4 injections. So the injections are 12 hours apart. But
right. Either way, it's 48 hours.
It's 48 hours.
And option A with betamethasone, you get an injection at hour 0, an injection at hour 24.
Yep.
You're done getting your injections, but we say 48 hours because it has to take effect in your body. And with dexamethasone, will be given at 0, 12, 24, and 36. And it's, for whatever reason, certain steroids will work. They'll go through the placenta, get to the baby. Like the type of steroids people take, like if they have an asthma attack or this, it's like prednisone pills, and those different.
Beneficial.
So someone who takes oral steroids for some reason or another, we tell them that's not going to work for the baby generally. So it's really just almost everybody uses one of these 2. And like you said, betamethasone is working out. So let's say mom is going to get steroids. What is, just in case, are there any downsides to her to getting these steroids? Like people think, steroids have always side effects and this or that. Like, does she have any of those?
So steroids in this sense are actually pretty safe. They don't have, like a very large immunosuppressive effect, things like gaining weight, things like, people worry about things like that. The one thing that, we come across often in pregnancy is sometimes they can't increase your sugars. We have a lot of patients who have diabetes. We need to follow that. That can also impact the baby as well. So, that's kind of the most important thing that we're paying attention to for mom.
I would say that almost more than 9 out of 10 report nothing. Like my arm hurts, I got a shot, like that type of thing.
Yes.
Okay, fine.
You can feel it.
It's like a flu shot. Like, not pleasant. And then some people have told me that maybe during those few days they have a harder time sleeping. Now, is that because of the steroids or because they're now in a stressful situation that we're giving steroids? Hard to tease that out, but I don't know, it could be the steroids, and that's a possibility. And then yes, those who have diabetes, their sugars are going to go. We don't it doesn't cause people to have diabetes.
No,
but if someone has it
doesn't.
and they're like, hey, my sugars have been normal and now they're high for like a week, the steroids absolutely can do that. And then long term, it doesn't affect the mother at all because it's just a much shorter course, right? When someone gets steroids, like someone says, I was put on steroids, usually it's 1, 2, 3 weeks of steroids, not 2 days.
Yeah.
And so 2 days of steroids won't give the same side effects. So someone is getting steroids and they deliver prematurely under 34 weeks. And, we're not happy they deliver prematurely, but we feel like, good job. We got the steroids on board.
we chose correctly.
Yeah, we did a good job. So let's see someone doesn't deliver, right? We think someone comes in, let's say, I'll give you a scenario. They come into 28 weeks. They have contractions. Their cervix is dilated. We think they're in preterm labor. We do A, B, and C. And we say, you know what? We're going to give you a course of steroids. So she gets steroids. This is a Monday. She gets steroids on Monday. She gets steroids on Tuesday. And she's still pregnant, right?
Very common scenario.
She doesn't deliver. The labor stopped on its own, or we gave her something to stop it and it worked, or whatever it is. And now it's a week later. So I'm going to ask you a few questions about that scenario.
Yeah.
So the first question is, does that mean we made a bad decision?
The answer is no. We didn't make a bad decision.
We never make bad decisions. Yeah. Never.
No, the answer is we made the best decision with the information we had at the time. And, especially if you're on the earlier side, the baby would get the most benefit really in the first 48 hours to 7 days after we give it. So if we think you're going to have an earlier delivery, it is important to give it. But the answer is, we still do have one opportunity.
Right. We're going to talk about that. So don't jump ahead.
Okay.
I know you're predicting my question. My second question is, you're answering the third now, but I'm going to go to the second. My second question is, we gave steroids and she didn't deliver preterm. Did I just do something harmful? Right? Meaning it's like, oh, I can't believe I didn't deliver. We just did something bad.
No, the answer to that is no.
Right. So good. So it's not, as far as we know, everything this has been looked at a lot, giving a course of steroids and then the babies deliver many weeks later, full term. They're fine.
Yes.
So it does not impact them negatively.
Yes.
So the third question, which is you're going to answer, which is the great one, is, okay, did I just miss my window to get steroids? And I'm 28 weeks. What if I deliver it 31 weeks? If I just are we hosed? And so that's the question.
And so that's the hardest thing I think we deal with. So there's been a lot of studies in the past sort of looking at the idea of giving people multiple courses of steroids, even serial courses of steroids, because we do think the biggest benefit is in the first week, definitely within the first 2 weeks. And so what happens if we give more courses after that? And there probably are some downsides to giving serial courses of steroids, sort of say if you start at 28 weeks and then giving them all the way through.
Yeah, every week or something. Yeah.
And one of the biggest things that the studies found is an increased risk of growth restriction, the babies being on the smaller side. So the recommendation through all the studies that we have gotten is that you do have an opportunity to give one course of what we call rescue steroids. So another 48-hour course of steroids, at least a week, usually 2 weeks or more.
Yeah.
After the first dose.
Yeah. So when I was a fellow, a lot of these studies were coming out because it was pretty solid that we knew that steroids were beneficial. And then people were like, well,
let's keep giving.
Right. If the max benefits within a week or two, why don't we just keep giving them every week or two, right? If they seem to be safe, just keep doing it every week or two. That way you're automatically guaranteed, no matter when she delivers, that you'll deliver within a week or two. And the logic is there. And so when they studied it, there was some benefit because yes, babies in that strategy were all born, within a week or two. Steroids and the other strategy, maybe they were, maybe they weren't. But there was a downside, it seemed. So no one does that really, the weekly or every other week. Whether the downside is horrible, we don't know. But it was significant enough to be like, you know what, it's not worth it. But no one ever found a downside to just 2 total courses of steroids. And again, since it's 2 injections, that would mean 4 injections. Well, we call a course that 24, 48 hours worth. So yeah, and that's the sort of like, when I was saying before, it's like the Price is Right. It's sort of like, it's almost like Price is Right, but you get to rebuy, you get to buy in again. And so
one more chance.
And so, so you have an opportunity. So in that scenario that we talked before, someone comes to 20 weeks, we think they're in preterm labor, or they are in preterm labor, we give them the steroids and they don't deliver. And then let's say it's 2 or 3 weeks later, and now they come back and their water's broken or they're 8 centimeters dilated, and we know they're going to deliver the next day or 2 or whatever. You can give another course of steroids, and it has beneficial effect, similar to the first time. So that's so because of that, it becomes then an even more interesting sort of exercise and timing. And so the way I sort of do it, and I'm going to ask if you do it differently, is for like the first course of steroids, I'm much more liberal and giving it.
My threshold is lower, 100%.
Yeah, because I'm like, all right, the first one is always the earlier one. I'm like, this is the time where we really can't get it wrong.
Yeah.
Right? We do not want to go over on this one. So I'm much more comfortable giving them potentially unnecessarily than I am missing an opportunity.
Mistakes would be higher.
Yeah, 24, 25, 26, 27 weeks, whatever. It's like, you know what, if there's any significant chance that you're going to deliver early, let's just give them. And then if you do deliver the next 2 weeks, which isn't great, but if you did, you got covered. And if you don't, number one, yay, you didn't deliver in the next 2 weeks, right? Because we thought you would. And number two, all right, now it's a little bit later. You're 28, you're 29, you're 30 weeks. If something comes up, we could be a little bit more discriminatory about saying, all right, let's really only give them if we really need to, and we're pretty high confident that you're going to deliver in the next week or two. And then once you get to like 32 weeks again, your threshold might drop because you're like, all right, if you do deliver, fine. If you don't, you're already 34 plus weeks, and it probably doesn't make a big difference. And so it's sort of like with each passing week or two, your threshold's going to go up or down based on the circumstances. That's what I do. That's how I think about it.
That's exactly what I do. I tell people earlier on, my threshold is much lower to give it to you because it would have such a higher sort of impact on benefit if baby was born. And then that second time around, you're thinking, okay, is it real this time? Is it not? We have one more opportunity. And like you mentioned, we typically don't give the second course or the rescue course once we get to 34 weeks and not in that late term period.
Because it probably doesn't help much. And it's so interesting because like when we, from time to time, we deliver someone who's under 28 weeks or whatever it is, for whatever reason. And the pediatricians / neonatologists, NICU doctors will, when they come in and we're telling them, hey, the first question they're always going to say
is,
did they get
beta?
Did they get steroids?
When did they get it?
Yeah.
When did they get it?
That's all, because they who take care of the babies, the differences are so pronounced. They see it. They're like, this baby who's 27 weeks who got steroids is doing so much better than this baby who's delivered 27 weeks who didn't get steroids. And again, it doesn't mean that someone was wrong. Sometimes people deliver too quickly to get steroids. Sometimes it was not expected or anticipated. Yeah. So there's not always an opportunity to give it, but they see that and it's like, really, did you get where? Yeah, when? If yes, when? Good. All right, fine.
Okay.
And and if not, they're like, oh, you sure we have to deliver? Because they really, and that's the proof is in the pudding, so to speak. The ones who take care of the babies, that's the thing they care about the most. And so we take that very seriously, obviously. And so it ends up being a large part of our conversation. Like when we meet as MFMs to talk about, almost every day we're talking about the decision to give steroids, to give them, to wait.
We talk about this all the time. It's always like group consensus. Like, is it time? Is it not time?
Yeah.
What do people think? And it's trying to predict this.
Yeah, because again, it is a very interesting phenomenon. And then we didn't cover this today, and we're not, but there are other things sort of in the same like category, that we sometimes give, like magnesium is one of them. Yep. And so, sometimes a similar concept that for different outcomes, but magnesium can be helpful at certain times, antibiotics. And these are the things that we do. But again, the concept is to improve outcomes for the baby by treating the mother prior to birth, which is again, I still think it's just really cool. Yeah.
And we're doing the best with the clinical knowledge that we have, the scenario, but new scenarios come up every time. So like you said, sometimes we don't get it right. Yeah. We do the best that we can.
Good stuff. Dr. Muoser, Celia, thank you for coming on the podcast. How'd it go?
Thank you for having me.
You're a natural.
Good.
You did good. You'll be hosting soon.
Easier than I thought.
Great. Thanks a lot.
All right. Thanks.
Thank you for listening to the Healthful Woman podcast. To learn more about our podcast, please visit our website at www.healthfulwoman.com. That's HEALTHFULWOMAN.com. If you have any questions about this podcast or any other topic you would like us to address, please feel free to email us at hw@healthfulwoman.com. Have a great day. The information discussed in Healthful Woman is intended for educational uses only and does not replace medical care from your physician. Healthful Woman is meant to expand your knowledge of women's health and does not replace ongoing care from your regular physician or gynecologist. We encourage you to speak with your doctor about specific diagnoses and treatment options for an effective treatment plan.